Department of Health and Human Services Heart Disease and Stroke Prevention Program, Henry Ford Health System, and the Michigan Society for Cardiovascular and Pulmonary Rehabilitation. We would like to welcome you to the second webinar, The Pearls and Pitfalls of Restarting Cardiac Rehab During the COVID Crisis. Unlike the first webinar, we would like this to be more of a town hall format. We will begin with 3 panelists, and then we will open for discussion. Many of you might know me from the first webinar. My name is Karen Fuller, and I'm a public health consultant with the Heart Disease and Stroke Prevention Unit. I serve as a community clinical lead specialist, and I also serve as a Million Hearts co-lead for the Million Hearts National Initiative. As part of our CDC grant-funded work, we have teamed up with Henry Ford and MSCVPR to increase referrals, enrollment, and participation in cardiac rehab. Next, I would like to introduce our speakers. We will first begin with Dr. Stephen Catane. He serves as the Director for the Cardiac Rehabilitation Preventative Cardiology Unit at Henry Ford Hospital in Detroit, and is one of our recipients for the CDC 1817 grant. Diane Perry is a certified clinical exercise physiologist and a certified health and wellness coach at Michigan Medicine. She has 20 years of experience working in cardiac rehabilitation and diagnostic stress testing. She is also the chair for the Patient Family-Centered Care within the Department of Preventative Cardiology. She is a member and past presenter of both MSCVPR and AACVPR. And last, we will have John Silvery, who serves as the supervisor for the Cardiac Rehabilitation Non-Invasive Unit at McLaren Macomb in Mount Clemens. John also serves as the Outcome Chair and Committee member for MSCVPR, and he assists MSCVPR in the 1817 work with us as well. There are a couple housekeeping things I'd like to touch on before we begin. We ask that you please keep your phones and computers muted. For those of you that have joined via the Teams link, you will find an icon at the bottom next to the end call button to bring up the chat box. So feel free to use the chat box to ask questions at any time during this discussion. Dr. Catane, I will pass the ball to you.
Thanks, Karen, and hi, everybody. I want to just, before doing my little opening, I just wanted to emphasize that the purpose of this, next 45 or 50 minutes or so is just to give us all a chance to share some of our ideas that we've been reopening back up our programs. This is new frontiers for all of us. And I personally would like to learn from any ideas that you might have as you hear others talk, share ways that you think might assist them with running a specific point or piece of cardiac rehab operations. So it really is supposed to be networking and kind of a town hall setting. Now, I know with 30 of us on the call that it could get a little unruly, so we may have to make sure we give give courtesies for everybody to speak. Relative to Henry Ford, I think we opened up our program in and around Memorial Day, maybe a little bit before, a little bit after, I forget. We have reopened to all patient types, so we're not trying to stratify those that might be more recent, those that might be older, those that might be, with a VAD or without. I think the only one that we're maybe consciously still trying to be aware of is anybody that might be in some type of window for cancer treatment with medications that could affect the immune system. Otherwise, we've pretty much opened up our doors. I would say one of our struggles right now is just program inefficiencies, whereas we used to be able to see more patients with 3 staff in a class, but due to trying to keep some type of physical distance amongst our patients, we're now only keeping maybe 4, 5, 6, 7, 8 patients in the class. It depends upon the location and the room size. But as a result of that, we've had to add more classes, and I am concerned about just, is there time for staff to get lunch, or is there staff burnout because they're on the floor so long during the day? It makes for long days. So that, we have opened back up, and I'd say the thing that's concerning most to me right now is just the inefficiencies of running a program before, compared to before, where we were fairly efficient at doing it. And then there's a whole issue of wiping down and wiping down all surfaces and equipment, although that doesn't seem to be quite as burdensome. I'll also say that our patients have been very responsive. They've been very cordial. They've been very appreciative of all the work that we seem to, or they see us doing on their behalf in terms of trying to keep things clean. They've been on time. In the city of Detroit, sometimes attendance is a little bit more of a struggle than that, or normally, but they've tried to be on time. And this is even with trying to keep them outside the building until their appointment time, and then they come in very close to that and do it that way. The only other issue I would bring up is that as I just talked to staff, I've got some mixed messages on patient interest. Some patients still don't want to come back. Some patients are ecstatic to get out of the house. Some patients don't seem to be concerned about coming out and catching the virus. So that's some input that we've had. It seems to be a mix at some of the that's some of the patient level feedback that we've gotten so far. So Karen, let me stop there just in terms of opening remarks. I'm welcome to hear from anybody after Diane and John have spoke. I'm welcome to hear from anybody in response to anything that I've said.
Great. Diane, you could
Yes,
go ahead and
sure.
thank you.
Can you hear me?
Yeah, we can.
Okay, so I very similar to Steve's scenario. We started in June 22nd. We opened our doors. Basically, after our walkthrough with infection control, we determined initially that we were going to just go with 8 max patients right now. However, we were told that we could hold up to 20 in the gym, but that would mean 16 patients. The rest would be staff. As of now, we're still just at 8 right now because we just want to see the flow, how it goes. There's been some procedural changes, of course, with the cleaning, so we want to make sure staff is comfortable. The biggest drawback for the patients is this idea of wearing the mask when they come to exercise. But the ones that are coming are being very cordial and understanding about it and trying their best with it. The screening for us is still, like many of you, they come through the front lobby of Domino's Farms. They'll have a screening, and then they come into our clinic, and there's a few additional questions before they come down to the rehab gym. We are encouraging e-check-in with the patients. We're really helping them to learn and navigate the portal because this has been helping to streamline that process. Some of the highlights that we did is we did go ahead and put together a safety video. This came out of our patient family-centered care. Those advisors said, hey, this is what we need to feel comfortable to come back. So we're doing that, and we're pushing that out. Our intake coordinators doing that when they set up their appointments. We send that out ahead of time so the patients can view that and feel more comfortable, hopefully. We're being a little bit more creative with the education. So we're having Zoom classes with the registered dietitians throughout the week. We're creating videos on our stress management and our experiential techniques for stress management so that we could push those out to patients as well. We still are having our group orientation because what we're finding from patients is that with the safety measures put into place for COVID, they're saying that we're missing the human element here, and we're starting to feel like we're just being herded in and herded out. So we can hold 8 patients in our conference room, social distancing. So we had our first group orientation with patients only. They wore masks, but they were able to share their stories. We went through how we approached the navigating the waters of heart recovery and the emotional process. We then showed the safety video again for some who missed it. And we are also in the process now of, we've got some patients who don't feel comfortable, so we have implemented a hybrid program for those patients. So that's kind of where we are right now.
Great, thank you, Diane. John, would you like to go?
John might be on mute.
Yep, let me check here.
I'm off mute now. Sorry.
Okay. No problem.
My name is John Severi. I'm the supervisor over at McLaren Macomb. I've been working in cardiac rehab for almost 18 years now. And through the years, and struggles that we've gone through with cardiac rehab, I noticed that this has probably been, like Dr. Stephen Contain said, new territory for all of us. So when we reopened back on June 1st, we contacted a lot of the previous patients that were pre-COVID, which took more time than what we thought would, in making sure the insurance was still covering. There's a lot more legwork, and probably like most hospital systems, like our hospital system, everything's about numbers. Everything is about, productivity, making sure we are staying in tune with everything. So, like Dr. Stephen Contain said at Henry Ford, we added more classes as well. We are a 10 monitoring system. So what we are doing to help turn around and making sure things are cleaned efficiently, we are using the first 5 monitors for one class, putting those off to the side so we can clean them, and using the second 5 monitors for the second class. So we have good turnaround, making sure everything is cleaned appropriately and properly for the patients that are coming in for classes. We have added more classes. We used to just be a 3-day-a-week phase 2 program. And under Medicare guidelines, as long as they are, getting 3 exercise days per week, some of our patients were only 2 days a week. So we started monitoring patients more on those off days to add classes as well, because we are maximizing, because we do have physicians all 5 days here at our hospital for that coverage. So we're just coming up with different techniques to maximize ourselves with the classes, giving the patients the chance to come into exercise. Most of the attitudes have been really great. I think most of the people want to get out of the house and to exercise. A lot of people are being very compliant with using masks and wearing the masks. We do have some patients that are difficult while exercising, and if no one is around, we do have them bring their masks down a little bit. But if anyone walks by or if anyone's coming to talk to them, they have to bring their mask back up to cover. Our staff is all wearing masks and safety glasses with every class now. Other hiccups that we came across with, and most cardiac rehabs have shown, is a lot of people go on hold, or a lot of people have vacations or other medical conditions that has slowed down their cardiac rehab. Sometimes you are able to hold those slots, but since you are so limited with patients, we had to come up with a different process of how to handle those patients that were going on vacations. So if we could fill those spots, because how we said, we're a hospital looking for the productivity and you have patients waiting. So it's kind of trying to figure out what was the best way of handling those type of patients, and how long they could be on hold for. Other issues that we came across is the financial clearance. A lot of our people that used to do the financial clearance were on furlough. So at this hospital, we never had to do our own insurance checks. We are now, I have gone and taught my staff of how to call these insurance checks and to get that. And that also takes time when you're limited staff, when you only have 2 here in cardiac rehab that are covering classes. And then also doing the additional legwork of orientations, doing the care plans, making sure the surveys get filled out for AACVPR. So there's a lot of things that we've come across and working through and trying to space out everything appropriately for all the workers, and maximizing our time as best we can. I'll kind of leave it at that and kind of open it up to other further discussions, or, you know, if Dr. Stephen Catane or Diane want to add to what I just spoke about.
Yeah, thank you, John. So I want to thank you all, Dr. Catane, Diane, and John, for getting us started. We can move into the discussion now. This is the meat of what we want to do today. We can definitely learn from each other. It sounds like there's a lot of similarities between the people that have started out this conversation. Diane, there was one question for you I want to get to in the chat. But for those that are connected through the Adobe, or excuse me, through the Teams link, there is a raise the hand feature, or feel free to ask your question in the chat box. And for the individuals on the phone, if you could unmute yourself when you'd like to ask a question, and that can be done via *6. But Diane, the question is, are you requiring patients to wear a mask during exercise? Are they permitted to remove it during their workout?
So we're very similar to John in that we are requiring them to enter the clinic with the mask and to wear it throughout exercise. However, if they are with just 8 now max that we're having, we can properly social distance. So if there's nobody directly in front of them and they need to, we're allowing them to pull the mask down for a couple good breaths, or, you know, to step out and do something like that. But if they're ever around any staff or anybody is in their close proximity, they have to have the mask on.
Okay, great, thank you. I also did include some questions in the chat box to consider, things that we could chat about today. Some questions are, how are you dealing with COVID-imposed program inefficiencies? Has your method or model for delivering the program-driven patient education changed? And the attitudes that patients are bringing with them, are they reluctant to return, having no problem with returning? So those are some things we could also talk about today.
Karen, Stephen here. I would be immensely interested to hear from others about patient care, patient education delivery. Have they suspended it? Have they used an alternate model? Any comments from others, John, Diane, and anybody that's tied into this? I would be interested, because that is, we are struggling with that. A couple of our sites are doing fine, and a couple not.
I can answer that for what we're doing, Steve. So, you know, everybody does things a little differently, but for us, we've always done a case manager model. So we used to work in pods, so that'd be a group of 3 of us as a team in the morning, and then a different group in the afternoon. So now we've combined those teams to have more staff, and we're actually running all day long now, kind of like how your program is. But because we have case manager approach, we're also still delivering on the floor, because the patients have that rapport with that case manager. That case manager knows what they need, what they're missing. So we're still educating on the floor, keeping a distance with our proper PPE and the patients. We're still educating on the floor as we can. As far as stress management and exercise goes, like I said, we're working to put that into video format that we could push out so patients can have those links and watch them at any time they want. But right now, we're still doing them on site, and we're bringing that group of 8 in the class for exercise. As they cool down, the last 15 minutes, they come into the conference room, and we social distance them and do the education that way. Our dietitians were sent to remote work, and they continue to do so. My knowledge is that they may be remotely working through August. So what we did is put all of the classes on Zoom with a link that we can send through our cardiac rehab email. We also have it on a calendar that we can hand give patients on site. So all the topics for the month are on there, and they can just click on any day that's convenient for them and watch those videos and be a part of the discussion.
Good. Okay, thanks.
Great. Does anybody else want to comment on that? We do have a question in the chat box from Christina Beal. As a furloughed exercise physiologist, what have the different hospitals been experiencing with returning to full staff and patient loads?
Karen, Stephen here, and again, John, given your supervisory role, maybe you can weigh in, but
I was just about to.
go ahead, John. Go ahead.
So to answer Christina's question, we're actually experiencing that at this moment. We have to basically structure what we are doing to help bring back furloughed exercise physiologists. The one thing that's nice about my site and what I supervise is I also look over non-invasive, the stress lab, and our exercise physiologists run the stress lab. So that has been helping me with bringing additional exercise physiologists back to help tag team. So when stress lab might be low, I can pull those resources to help assist in cardiac rehab within the needs of getting more patients in. But a lot of the structure of bringing the additional exercise physiologists back is really based on how we want to bring back almost our maintenance program, which we are coming up with a return process for them, about 5 to 6 patients as well, and using different time classes. Before, we used to be an open gym, but we're looking to establish closed times for our maintenance patients to return, with almost the same structure as we do with our phase 2s that are monitored. And by bringing those individuals back, that also helps bring back the additional staff. And that's, and it's really about the productivity with the hospital is what we're looking to see, that what we need to provide. So in roughly, hopefully that answered the question, but I don't know if I answered it fully.
I could share a few comments. This is Diane. John, I totally agree with you, because it is about utilization right now, right, and productivity. So we're in the same boat. We have testing, so we can work on bringing some of these EPs back for the testing element of it. But I'd encourage you too to think outside the box, and we've talked to staff about being flexible and being creative, because with COVID, we have certain restrictions, and that brings up barriers, right? Like education. So we've talked about bringing these EPs back, and they're working in different roles right now. They're working on trying to put education on a virtual platform for us, even though maybe they usually test, or maybe they usually do something else. So, being able to justify that we want to bring numbers back and increase utilization, but still bring the same quality program to our community is really what we're going for. And so we're using this angle to bring staff back. So, we're using them in different capacities. They're learning new things, but it's a good thing.
Great, thank you. There is another question in the chat box. There's some discussion and a chat, but and questions. But is anyone offering phase 3? Is a question from Darby McCarley. Is there anybody on that wants to chime into the phase 3 question?
This is Diane again. We do have a very prolific phase 3 fitness center, and this has been kind of something that's been our barrier right now, because we have a community that's been grown through that group. And right now we are not running it, I can tell you, because we're using the gym to be able to social distance as many people as we can in the phase 2 queue, which we feel is the priority right now. But we are reaching out to them virtually. We have talked about the discussion of creating some kind of Zoom exercise classes for them so they can still reconnect, and maybe even have weekly calls with various staff members just to keep them together. I know our patient family-centered care came through there, so I just heard from one of our patients on that committee that they on themselves have chosen to connect with one another. They're emailing and calling each other and trying to make time to get together in small groups for exercise, but we are not running it on site right now.
So just an add on to Diane's comments, at our physically, Stephen here, at our physically smaller locations, we've not restarted phase 3. At the one location where we have more of a medical fitness center setting, we had started phase 3, and I can tell you we've done it by appointment only, so to speak, or class appointment only. So we may offer a weights class or a floor class or a yoga class, or just a free exercise, free machine class, so that we might put 10 or 12 people in a class. So they kind of schedule by appointment. It seems to have gone well, and we're able to spread out sufficiently for them to do that. We've also used a virtual platform where we've either done, led exercise or had a forum or something like that to keep connected with the patient. So this is a challenge, because these tend to be loyal people, as Diane was referring to. You build up a community, and it is a challenge to get them re-engaged, or they want to get re-engaged, and we can't meet their needs. So, but in a limited way, we've been able to do that, and it seems to have worked well.
This is Laura. May I add to that?
Sure, yeah.
Can you guys hear me okay?
Mm-hmm.
Okay, good. Where I work, we have not brought back any phase 3 patients at this time either, because of a space limitation, but it has turned out to almost be like a double-edged sword. We have more time to work with our clinical patients. We feel like we can offer them a more individualized experience, and we get to really spend a lot of time with them. But then, because those volumes were added into our productivity numbers in the past, now we're having to explain ourselves to leadership why it looks like our volumes are so far down. And then also, without that phase 3 program, some of our patients who are higher risk, even though they had graduated from phase 2, are not maybe appropriate to be exercising on their own outside while fitness centers are closed. So something we've been thinking about for long term is maybe having admission criteria for phase 3. So offering it still to a subset of that population who they have heart failure, or their functional capacity is only 2 mets, or they have some other limitation that would keep them from being able to be successful on their own.
Great, thank you, Laura. Does anybody else have anything to share? I can move on to the next question in the chat box. Please feel free, if you're on the line, to chime in at any time. Stephen asks, any suggestions, policies for patients that don't attend constantly? They are enrolled in program, but inconsistent with attendance.
I would love to speak to that one.
Yeah, please do, Laura.
Okay. We have instituted a 3-strike policy, because at this time, with space being limited, if this person is in the same boat we are, where you have a limited number of patients you can fit in the gym, if someone doesn't show up or has a same day call off, then we count that as a strike against them, and they're taken off the schedule. Informed of that, we leave them a voicemail or call them and let them know, you've lost your spot. If you want to come back, you now have to call us to get back on the schedule. And your heart goes out to people because you want to be flexible, but if they don't even give you the courtesy of a call so that you can fill the spot with another person, I've just been very honest with people and said, when you don't show up, then I get sent home because we don't have enough volumes. And I think that's worthwhile, to have that honest discussion with your patients so that they will be adherent And then that's what's best for them too. If they're not coming routinely, then are they really benefiting from the program? Not as much as they could be.
This is Diane, and I fully agree with Laura. We kind of did a similar thing. We kind of have we call, twice, and then on the third call, it's kind of the third strike. But I think it's really just all in how you communicate it. And just like Laura said, early on that first session, if you can communicate it for us, we do it in the group orientation. We talk about how many people are in the queue, helping them just be compassionate and understand for their fellow classmates that people are waiting to get in. And, we try to work with them. If they tell us up front they already had a vacation planned, we work with them. We want to know the dates. We want to know when they're going to be back, and the expectation is they're back. But we're laying it all out ahead of time now so that it's nothing new. If they get that call, they've heard it.
Great. Thank you both. I don't see any additional questions in the chat box.
Karen, I think there was one a little bit higher up. I think this one goes to Diane. I think it's related to the patient education videos that she was discussing. Steve asked if you're able to track which patients are watching the videos.
We can, because the dietitians are actually taking attendance, so they know our patients, and so they're letting us know who came. So far that's the only one we have on Zoom. We're hoping to get the rest of them on, but like I said, the rest of it's either being done on the floor or in a group education setting with just low numbers.
Great, and we do have another question from Christina Beal. Does anyone still allow patients, a spouse or significant other, to attend the education orientation sessions?
This is Diane. No, we're not doing that at this time, just because we can only have 10 in the conference room, and that includes Carolyn and myself as staff. So we're telling them on the intake call when it gets scheduled that we're going to have them just come without a family member. But one thing we are working on looking to do is create a Zoom support group that's going to meet once a month. And our hope then is that we can have patients and family members join that.
And Karen, Stephen here. I would say we've tried to be flexible on that. Like Diane suggested, we start off with support person or spouse or support person not being with them. But in certain situations, obviously, it is needed that way. If we're in a conference room that can handle an extra person in the room and still keep physical distance, then we'll go ahead and do that. If not, then we might just do we don't like to, but we might just do a one-to-one orientation, or in this case, 1-to-2, because the support person's with them. We'd like to keep the group orientation if we can, but if the room won't allow that extra person in there, then we'll go to individual. But we do start out with, usually it's just the patient only coming in.
We're the same at McLaren Macomb. We have the hospital policy with visitor and guests, how many people can come in, and unfortunately we are not allowing the spouses to come in. So if there's any additional information, because we're doing a lot of the education during exercise classes, so if we feel that a significant other or other people need to know this information, we've been doing phone calls with those significant others and kind of talking to them on the phone, or encouraging the cardiac patient for their spouse to call us if they ever had questions or concerns, and doing a phone call with them as well.
Great, thank you. We do have another question. Is anyone doing face-to-face assessments? Stephen says, currently doing a phone call assessment and a physical check-in when they come in.
This is Diane. We're doing similar, just the phone. intake and then the check-in on their first day.
And Laura commented in the chat box, since you can't bill for a phone visit, they're definitely doing in person. So billing is definitely a driver in that. And Vicki commented in the chat box, the main program is doing face-to-face, but PIPP location is doing orientations on the phone. Not sure what PIPP is. Vicki, if you can elaborate, maybe if you want to maybe unmute yourself and speak, that would be wonderful too. Okay, she commented it's Ascension, Borges, PIPP, and Plainwell. Thank you. And it's a smaller program. I'm not seeing any additional questions in the chat box right now. Vicki did comment that they offer both. The patient has the choice if they want to do the phone or they complete pre-rehab paperwork online. Okay, we do have another question in the chat box. Do most have all locations open or just the main hospital?
Karen, Stephen here. We've got all of our sites open within the Henry Ford Medical Group. I know Henry Ford Macomb is open and Henry Ford Wyandotte is opening. So I think we're pretty much there within the Henry Ford system.
Currently, Michigan Medicine has all their sites open.
I would add that given although the number of people testing positive for COVID is inching up a little bit in Michigan, the number that's actually, at least in Detroit, that are being hospitalized is still very, very, very low. And I think everybody's aware that the number of deaths in Michigan is still smoldering around the lower end of the numbers. And the reason I mention that is that I think now one would be hard pressed not to have their program open as we're this far into it, and would encourage most programs using whatever controlling or organizing systems or policies they can put in place to, as we've been talking about, to do that in their sites as well to get their program opened.
Yeah, and thank you for sharing. There was some additional comments in the chat box. It looks like there are some hospitals that have sites that are open, and somebody wants to know, Laura wanted to know, does anybody know about Beaumont sites, if they're open or not? Doesn't sound like anybody knows, or maybe nobody from Beaumont is on the call today.
This is Diane. I can only say that we had a patient transfer. She had one session there. I don't know when it was, but she just actually started yesterday, and she transferred over to us. So I'm assuming then that they are open, but
yeah, and Christina just commented that most Beaumont sites are open. So thank you. Yeah, great. And I'll pause for a couple of minutes and see if there's any other questions that come in.
I do have a question, but it's not related to cardiac rehab, but it's related to testing. So I would like to just ask Steve and John their take on it. You guys requiring COVID testing prior to a stress test? Yes.
Diane, Stephen here. The short answer to that question is no.
Okay.
If you look at the pre-procedure testing in Henry Ford Health System now, I think we've probably done 30,000 pre-procedure COVID tests. Somebody coming in for a cath or a GI surgery or something like that, and they'll get tested within 24 hours before.
Mm-hmm.
I think right now it's running at about 3 positive patients out of every 1,000. So again, the background noise is very, 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 very low, or background prevalence is very low.
Okay.
So that gives us, along with all the screening stuff we're doing, great confidence. The other thing I would mention that for our CPX tests, the cardiopulmonary exercise tests,
Yep.
there is a filter that Medgraphics makes that you can insert in between the mouthpiece and the line for the metabolic cart, that has a filter in it. It adds a little bit more weight to the patient's apparatus that they have to support. We have a suspension device that helps with that.
Right.
But they claim it filters out 99% of particles less at 30 microns or greater, and that would catch COVID. But in real world, at higher ventilations, it's probably only filtering out if the person's infected, which we hope they're not. It's low prevalence.
Mm-hmm.
It's maybe probably a little less than that, but it's probably above 90%. And the patients tolerate it fairly well. So we've used that. It's gone pretty well.
Good. Okay. And then the staff just in the usual PPE, they're wearing
Sure.
face shield and mask. Yeah.
The person taking the blood pressure that's most proximal to the patient during the test does have a face shield on.
Okay.
The supervisor for the test that might be in the room certainly is masked and gloved, but not necessarily face shielded. Again, very low prevalence of the disease in the patients that are being tested, and we've got this extra filter. Plus, there's building screening. Plus, we have this extra filter that's going on that's run in parallel with the system.
Gotcha. Okay. So if you were to schedule these patients based on your initial call and just the usual screening questions, does that determine if you do a COVID test prior to testing, or just across the board, nobody's getting the COVID testing?
So nobody's getting COVID tested, and if somebody has any, within 14 days, because those are the questions we ask, right?
Right.
But then they're not getting tested.
Okay.
We do that building and phone call screening, but it stops there.
Okay.
Over at our site, Diane, is we're not doing any testing. When we started to do outpatient services, if anyone was tested positive for COVID, we did retest them in the beginning, but that has stopped. That's when it was still kind of it's heightened. That was like early June when we were reopening everything.
Yep.
So we have stopped, but everyone's still using the proper PPE, depending on the stress test. Like a stress echo, my sonographers are wearing face shields, and they are still wearing N95s during those procedures, just for the safety and courtesy, because how close they are with those specific stress tests. So
sure. Okay. Thank you.
It looks like we got another question regarding pulmonary. We do share space with pulmonary rehab at McLaren Macomb, but we have not brought back pulmonary rehab at this time, just due to the patients that are vulnerable for COVID, and we're still weighing out the safety for those kind of patients, and the timing that we can use that space adequately enough for those patients here at our site.
Yeah, thank you, John. Does anybody else want to comment on whether or not they're bringing pulmonary patients back at this time or bringing them together with the other patients? And another question we got is, how about staff being tested for COVID prior to returning to work or once working?
So at Michigan, we're not required to be tested. We do have a screening process that we do every morning through our, we have a link that we go to, take our own temperature, and then we answer those questions. But outside of that, it's really, we have the hotline. If we have any reason to believe we had exposure, we go to the hotline, they go through the usual questions, and then it's determined if we go into quarantine, and then it goes through the contact tracing of then who else needs to go into quarantine.
Okay. Laura put a question in the chat box. Is everyone meeting patients at the door to screen them prior to exercise? Is there a way around this inefficiency?
Well, for Michigan Medicine, our cardiac rehab is housed at Domino's Farms, which is a very large complex that has many different businesses within it. So within our lobby, we have med sport, PT, and plastics, and a dentist office. So we have rotated duties among these 4 clinics, front lobby, asking the initial screening questions and taking temperatures. Then those patients go into their respective clinics, and there may be a handful of other questions that are asked. And then our patients are just being sent down towards where the gym is. They social distance on markers on the floor outside of the rehab room, and staff comes and brings 2 in at a time. So to answer that, I guess we're sharing, like right now, we've set it up that we share those duties for that very front lobby screening with some other departments, other clinics.
The inefficiency that Laura brought up is all part and parcel of what I spoke to earlier on, Karen, that things are just so much more inefficient now in terms of operations than before, back in February or January. And it'll be this way for, months upon months upon months now. And we're going to have to adapt, but I encourage people to keep their eye on the cardiac rehabilitation ball, that we've got a lot of patients that still have heart problems. We still need to get in. We're still worried about, our enrollment numbers. We're still worried about, patient education. We're still worried about outcomes. All that is now, I don't want it to be buried underneath, but it's got to be layered within everything else that we have to do relative to COVID. We've still got to keep our eye on the ball that cardiac rehabilitation is what we do, and it plays an important part. And we've just got to interface this with everything else that's now kind of thrust upon us, and that's making us more inefficient.
And I'm going to piggyback on that with Steve. Again, it goes back to bringing back staff doing things differently. We have a couple of our exercise physiologists that went back and were put into scheduling classes, so they know how to schedule, and that helps. We're also having people take the time to actually educate patients on the portal and e-check-in. And because a lot of it is a fear factor, some patients just, the technology is scary. So we're having staff who are comfortable in that way, becoming educators with patients to get past that barrier and just spend time with them, sit with them, show them on their phone how they do it. Once they're in, they're like kids in a candy shop. They think it's the greatest thing ever. But that really expedites the process of check-in if they can use e-check-in.
Yeah, thank you for those comments. We do have some additional questions in the chat box that I would like to get to with the final 10 minutes remaining. What are the program staff to patient ratio? And that probably varies.
5 to 1.
5 to 1. And Jody commented 1 to 3. So that probably varies a little bit on site and capacity. And Laura asks a good question. Does anyone have plans to remain open to a degree if there is another stay-at-home order?
Well, this is Diane, and I guess I could only share with you that in those instances, it's really going to be directed to us by our institution. So, you know, whatever the governor says, then it'll come to Michigan. Our leadership will make that call for us.
And yeah, Laura said she doesn't necessarily like that, but she understands. I was wondering, Laura, if you had access to voice, if you wanted to explain, but that's okay also. Does anybody else have any questions? Oh, she lost her mic. Okay. I'll give it a couple more minutes to see if anyone wants to have any more discussion.
Karen, as we get closer to wrapping up, I just want to, you know, formally thank you and you know, Adrian and Sahil. I realize this is a little bit out of your, over the past year or so, this is a little bit out of your normal, you know, sandbox. And now with COVID, we've pulled you even further into other activities. And so, you know, we certainly appreciate it. This kind of communication amongst ourselves is very, I mean, I found this very helpful.
Yeah, thank you for that acknowledgement, Dr. Katane. And on behalf of the MDHHS Heart Disease and Stroke Prevention team, we are happy to do so, and we will continue to partner with MSCVPR to proceed in increasing referrals, enrollment, and engagement. We understand that that does look a little bit different, as with much of our work, but thank you for that. And I want to thank everyone for their participation today, and thank you to Dr. Katane, John, and Diane for leading us off and even facilitating the discussion. I think it was very informative. It's interesting how there's so many similarities, but yet some differences across cardiac rehabs, and learning from each other. So this webinar will be available for people who either want to listen again or were unable to attend today. And if there's nothing else, we can close, and thank you all.
Thank you so much.
Thank you.
You're welcome. Have a great day, everyone.
You too.
Thank you. Bye-bye.